So yes, today's session is going to be on the eye and how, you know, a sick eye normally resides in a sick body. The eye is not some separate tissue from the rest of the body. In fact, the back of the eye is called the carotid. Dr. Carter, did I pronounce it right?
Hey, what now?
The vascular part of the eye, right under
Choroid? Yeah, choroid, yeah.
Choroid is the most vascular tissue in the entire body. Okay, so when you look at an eye disease, you have to look at it, at least in part, and maybe major part, as having a significant vascular contribution. So in that respect, the eye can be a canary for vascular disease, and we can certainly see neurological tissue very accurately in the back of the eye, which I'll talk about. But you know, one thing I've been talking about for 10 years to crickets is that the eye would be the most useful tissue to study athletic performance, because your very first interaction with the environment is a photon of light hitting the back of the eye, the retina, the photographic plate, and convert that photon of light into an electron. So everybody has a different rate for that process, and we can measure that very accurately. I won't be going into that today, but it's called a multifocal ERG, which measures the voltage being produced in the back of the eye when light hits it. So when you think of great athletes, Michael Jordan and Larry Bird, basketball players. Michael Jordan was this supreme physical specimen. Larry Bird was this ungangly, clumsy-looking 6'10" white guy. Why was Larry Bird just about as good as Michael Jordan? And it may be explained not by his physical stature, but by processing of the imagery really, really quickly. So like peripheral vision and reaction time, not the muscles, but actually having that signaling processing happening extremely rapidly. And when you're at that high level, a couple percent make a big difference. But anyway, I shouldn't digress. I should stick with the show. But anyway, what's important to see in this slide here is that the eye and the retina in the back of the eye is actually an embryological outcropping of the brain. And the hippocampus and the retina have a lot in common. But so here we have the light coming in, and back of the eye here, the retina, converting the photon to the electron. But then there's the optic chiasm, which goes across multiple synaptic junctions to the back of the brain. So, you know, in order for the information in the eye to be processed properly, it has to go across this entire brain tissue through a number of electrical connections to the optic chiasm, they call it the primary visual cortex. So why do we need to look at the eye? Because something's going wrong in the U.S. healthcare system in general. You've seen this slide before. This is cost on this axis. Let me reduce the size a little bit. Versus longevity. And we're losing the cost longevity battle. So we need better diagnostics. And if we could look at the eye not just as an isolated piece of tissue, but as a barometer or a canary for the whole, it might provide us with better screening, at least. And it's inexpensive, it's non-invasive. So this is the lecture I gave to a bunch of stem cell scientists, because the lens of the eye is actually a giant stem cell. So, and then a lot of things that we see in the eye, like a cataract, is related to what's going on with the stem cells in the periphery of the cortex of the lens. So we can evaluate stem cell health through the eye. We're basically doing a tissue biopsy in living tissue with the microscopy and other techniques we use to evaluate the eye. Once again, this was for a stem cell group, so I changed my talk a little bit. Lens of the giant stem cell, sometimes I talk about that, sometimes I don't. OCT is probably the best way to measure where you are on the neurodegeneration continuum. Now, if you've been around with me for a while, you understand the concept of focal infection. So in other words, you can have focal infection or focal disease. So you can have a disease just in the brain and it's not affecting the eye, so the eye won't be a barometer for that. But a lot of times there's overlap, okay? So OCT is just like MRI. What does MRI do? It creates three-dimensional images of tissue. And the wavelength of the electromagnetic energy they use to create these images is rather gross. It's like using a hammer rather than, tweezers, okay? So the images you get in the brain with MRI are kind of like gross images. They're not very precise. Whereas OCT, just like MRI, measures three-dimensional images, but we're using tweezers, not a hammer. So the precision and definition that OCT can provide of the neurological tissue in the retina is much more fine than MRI in the brain. So, we can actually see down to the micron level. So we can see down to the capillary level, whereas an MRI in the brain, you can't see capillary. All you can see is gross changes, infarcts like strokes or mini strokes, but you can't see the fine detail. There's over a dozen markers of test of the eye that you can use for evaluation. For example, just looking at fields. How far back can I see with peripheral vision? That starts declining in glaucoma, so I can't see as far back. Okay, measuring the electrical potential from the eye to the brain is something we can do. But just looking at dry eye, cataract, there are three types of cataracts: glaucoma, macular disease. All those are systemic diseases that tell us a lot about what's going on in your health. And just so there's no surprise here, how you really figure out what's going on when you see this as a screening tool is looking in the blood, looking for the inflammatory markers, and looking back to lifestyle to see that might have in your health timeline to see where something might have gone wrong. And then that gives you clues as to what went wrong. And then most of the time, those things are reversible, slowly reversible. Remember, if it took you 20 years to get into macular disease or glaucoma, it's going to take you 20 months to get out of it if we're really on task and doing it right. There's no quick fix, and I have a slide on that. Optometrists who do pathology, some just do refraction, which is measuring, what glass prescription you need. But there are plenty that do pathology, and it provides an inexpensive, accurate health risk. So what I do is I just refer you either through Vision Source or All Docs OD to an optometrist in your area. Normally they take your insurance, and I just give you a cue sheet to give to your optometrist to fill in the blanks on their interpretation of your eye health. And then we interpret it in terms of your systemic health. But any eye doctor that has an OCT, stands for optical coherence tomography, can do a complete systemic workup for you. But never go to them and say, oh, hey, eye doctor. My son just became an eye doctor. He's starting actually tomorrow, just got out of school. But you never go to them and say, hey, eye doctor, I want a systemic health evaluation through your eye testing. They're going to say, what? They may know how to do it, but it's not their practice. So you just want them to do a complete eye exam, and then, don't muddy the waters or shake things that shake up the hornet's nest, and then just get it to us and we'll interpret it. Interpreting eye data with or without an eye professional is easier than you think. I mean, you have to have the data, but in the digitized world, the outputs that these devices produce are like, knowing whether when you hit a traffic light, if you need to slow down, stop, or continue going. It's really quite simple. Where does the eye fit in? This is an old thing that I always used to say, lifestyle begets risks. Risks, if they perpetuate, lead to blood changes. Blood changes, if the risks in lifestyle perpetuate, lead to pathology changes, which we can measure in the eye. But there are other places to measure pathology: ultrasound, CT scanning, MRIs, things like that are looking at tissue. The blood Just because your blood's bad doesn't mean your tissue's going to go bad. But if you have a disease, the tissue's gone bad. So it's sort of, that's where the eye fits in sort of this continuum. But the biggest challenge I face, and the reason why I'm so happy to have folks like you listening to us, is that, we all want the instantaneous gratification. We're hardwired for that, especially with, these retarded instruments that just retard everybody. Sorry, a little commentary there, but, so we've been trained on instantaneous gratification. Everything's at our fingertips, but it does take, chronic disease is very different than acute disease. It takes patience, it takes precision, it takes, knowledge, and it takes, that's why anybody who signed up for my end of year program, I'm going to have you send me times and dates every week. I want to have at least 10 to 20 minutes with you every week so we can keep the ball moving forward. It's going to help me. It's going to help you. And, it's accountability. If you're measuring your blood pressure every week, I want to see how those trends are, things of that nature. We want to keep closer tabs on things. So, here's the same thing differently. Your risks will eventually lead to if you're in the wrong zone, to biomarker changes, to tissue changes, which we measure in the eye, to disease. A classic example is macular degeneration. Dry AMD. If you look at the standard of care, dry AMD is only observed, and they don't do anything until you have wet AMD. Wet AMD is vessels in the back of the eye literally bleeding, just like if you had very bad bleeding in your gums. That's not when you want to start treating. You want to start treating before. So a thing called drusen is just it's actually a pre-atherosclerotic plaque. It's like a zit, okay, which is, what a zit is, a pimple, is your immune system fighting something, in this case, acne vulgaris, which is infectious, and creating a pus sac of cytokines, of debris that your immune system is cleaning up from that infection. The same thing is going on in dry AMD. You have this little pus sac, this little cytokine sac, this little debris cleanup sac in your eye. Now, you may not need treatment. Your immune system may overcome it. That's true, because not everybody with dry AMD progresses to wet AMD. Some die before they get there. Some resolve, and that's where the blood testing comes in, so we can see where you are on that continuum and help you slide back down it. Does that all make sense?
Yes.
Appreciate the feedback.
Yes.
So here's the old thing about, 7 people analyzing an elephant from different areas. Oh, it's a rope, it's a wall, it's a tree, it's a snake, it's a spear, it's a fan. My only point is, if these people don't talk to each other, they'll never figure out it was an elephant. If we don't test more broadly and then have someone that can integrate this into a single story about you, you're never going to solve your health problem. That's the problem we have with healthcare today. Your practitioner is your PCP is solving acute things. Great, that's perfect. You need that. But then they're just shuffling you off to specialists who are working completely in a vacuum. Did anybody read Walter Isaacson's biography on Steve Jobs? Anybody read that?
No.
I think I have it on my bookshelf. I'll take a look. But the reason why I bring that up is about a third of the way through the book. This is Steve Jobs. A third of the way through the book, Isaacson quoted Colleen Powell, Steve Jobs' wife, about his care at Stanford, one of the best medical institutions in the world. And she basically said nobody was talking to each other about Steve Jobs. They all wanted ownership of Steve Jobs, and if you share information, they might lose ownership. So she said she had to completely take over, and she used the term, it's in my quarterback book, quarterback Steve Jobs' health. If Steve Jobs cannot get coordinated care in medicine, How can the rest of us? Crazy. Any comment, Michael?
No, I mean, that's absolutely correct. It's a sad testament to, how everything is, orchestrated out there. But of course, that is the benefit of what we do as functional medicine practitioners, and really, bringing all of the systems into one place so that you can really, dive deeply and figure out what all the causes are.
Yeah, it's the story. Very, very few people understand the connection of eye to the whole body. Very few. You can read the literature, and I was actually telling Dr. Carter this. Joseph Flammer and someone else from Australia and Switzerland wrote an article in 2006 called "Open-Angle Glaucoma, blah blah blah: A Sick Eye in a Sick Body." And a lot of people have read that, but they don't really know what to do or how to integrate it. And you certainly can't integrate it into the healthcare system in America because of the coding. But what I did here 2 years ago when I was on the Immune Defense Summit, I got almost 700 people to take my short survey, just 16 questions. And when you look at what they presented as how well you feel normally, eye issues were very high up on the list. And then when you look at all the chronic conditions they indicated, when you look at, of course, I'm the only one asking these questions about eye, but cataract and eye in general, and then glaucoma, eye diseases were at the top of the list of highest percentage of chronic complaints. So it's, but more importantly, from what we know, is that means there's a lot of systemic disease going on in our population. So it's not an isolated thing. And then this is just a slide I have. I was reading, can I walk away for a second? No, I won't. But I was reading Paul Ewald's book. He's an evolutionary biologist, and he wrote it 20 years ago. So he was projecting to 2020, and unfortunately we haven't moved that fast. But it's called Plague Time. And Dr. Carter, I've got to read you this passage because I just read it like 5 times the other 2 nights ago. And what he basically said is that genetic mutations are there to conserve a race, not eliminate it. So genetic mutations, if they're adverse to you, that population is going to die away. So in this study here, National Geographic, May 2013, I think it was called Getting to 100 Candles. They went, and I think I told you this in the Genesis of Health talk, but I'll say it again. They went, in the context of genes, they went to many locations with centenarians looking for the genetic connection to longevity. And guess what they found? More importantly, guess what they didn't find? The genetic connection. They said, lifestyle behaviors, this, that. And then they said, and 25% we attribute to luck. I love that statement. It's like, no skill, no scientific method, just luck. But the point is, when you read Paul Ewald stuff, yes, there are genetic things that are epigenetic, but true genetic predisposition, look, a rat's DNA is 85% the same as a human, a rat. So that means human DNA is infinitesimally different from one to another. So it's really hard to pin genetics on this huge upswing in the last 50 to 100 years of chronic conditions. It's really just lifestyle. So, 1% genetics. So I really like, I'm sort of an outlier in this space, but when someone starts talking genetics to me, I just like, there's so many things. And then genetics, I was talking to this gentleman yesterday from the Bronx, it turned out. And what was my point? Yes, genetics, what I hate most about genetics, it's a crutch. I'm not saying it's not real, Dr. Carter, but there's so many other factors. And if someone says, oh, it's my genetics, what they're saying is, I can't solve my problem. It's just the way it is.
Right. Yeah.
So let me give you an example of how we're at the infancy in understanding genetics. So the so-called alleles, the EPO allele, it's the 2, the 3, and the 4, and you have 2 of each. And so the double 4 is considered a high risk factor for Alzheimer's. But I've seen published literature where it says the double 4 allele is protective to macular degeneration, which just shows to me that they don't know what they're talking about, because macular disease is on the continuum of Alzheimer's. It's the same process. It's a vascular process in vascular tissue feeding the neurological part of the eye, just like in the brain. So you can't have it both ways. Okay, so it's like when Mendeleev, I know I'm getting a little technical, but it's like when Mendeleev started associating elements in families, okay? You know, we're at that kind of a early development of really understanding the genetic health connection. I think there's a lot of misinterpretation. If we look at a single gene, not the constellation, then we're probably going down the wrong path. But you may hear these alleles predispose you to macular disease. Let me tell you about Dr. Trump. He was doing allele testing 20 years ago. And before I met him, he stopped doing it. And I said, when I started learning about genetics, I said, Clem, why aren't you doing genetic testing? He said, well, I'll tell you why. Because I've had so many patients with macular disease, and I did the allele testing, and when I had one patient with macular disease with the bad allele, and one patient with the macular disease and the good allele, and I treated the patient, they both got better. So why am I wasting their money? Just a little sidebar. I'm not saying it's not important, but the genetics people are over promoting how important it is. That's all I'm saying. And that's why we do your CDA and CDT. We're not doing genetic testing. Anybody wants genetic testing, I'll put a program on there, because there's some very good programs out there for genetics. But my dad taught me to be very thrifty. My wife will tell you I'm too damn thrifty. Usually how it works, right? Actually not. I misrepresented her. She's very good. So here's something. One of my favorite things I've seen, and this appeared through my friend Dr. Loudon, who's not on today. He sent this article to me through the New York Times 3 days before I presented in front of the Academy of Comprehensive Integrative Medicine on the eye and Alzheimer's. And here's a 5-year-old in sub-Saharan Africa with a cataract, a nuclear cataract. And it says down here, cataracts usually afflict the old, but doctors in Africa have been shocked, I love that word, to find them in Ebola sufferers as young as 5 years old. So the only explanation for this is the cataract is an unfolded protein. It should be transparent there, but instead its conformation is different than what it should be. And that conformational change is actually part of your immune response to the Ebola infection. So now let's translate that to older people. Ebola is an acute infection, whereas long-term, if you have cataract when you're 60, you most likely have a chronic, stealth, undetected inflammation or infection. And your immune system sees it. And you can have local infection in the eye. Dr. Carter will talk about that next week. So that your eye is trying to protect itself. And I'll talk about this in a minute, Dr. Tanzi and Dr. Moyer at Harvard showed in Alzheimer's autopsy studies that cataract and Alzheimer's plaque are the exact same protein. They're called the beta 142 amyloid, which is supposedly the target for Alzheimer's. It's not. It's part of the innate immune response. You don't want to mess with that. But what was the second part of that is, these proteins he showed at Harvard, or they showed at Harvard, are immune response molecules. They're called antimicrobial peptides. So this is part of your body, just like white blood cells kill infection. these amyloids kill infection. And now that you're all, let me just show you, who knows what I had up here. I'm a cyclist, I'm a Tour de France fan, so I'm watching the tour, but let me just show you my books page. But you all have, if you're working with me, you all have access to my books. So if you haven't and are interested, fine. But the link is just healthybiblepartners.com/books. And this little book here talks about all the research. It's a short book, and I think everybody can read it. It talks about how amyloid in cataracts and other places in the body called amyloidosis is actually a sign that your body is, working to solve a problem in that particular part of your body. They are antimicrobial peptides or anti-inflammatory peptides, however you want to call them. And the best place to look at that is in the eye. Why? Because you can see them. If they're small, an ophthalmoscope that an optometrist has, which costs, $1,500, they can see them. So you don't have to tear open tissue and invasively investigate your body to see these processes. That's why the eye is so profound. Once again, it doesn't catch everything. But here's a chart that shows plaques visible in the eye, plaques detected in the brain. So the eye plaques, like a cataract, like a nuclear cataract, like a cortical cataract, like a what the heck's the name of the other cataract, Michael? I can't remember. Subcapular cataract, macular disease, drusen, give you a 15-year early warning sign for neurodegeneration. Always no, because of the focal factor, but in more systemic causation, definitely. Look, my dad had glaucoma 10 years before we realized he was having cognitive problems. So it's personal, but you can search on the Google Doctor web, Google, and put in Alzheimer's and glaucoma and see hundreds of papers discussing the association. So, here's how profound it is. There's the retina, there's the nervous tissue back here. And, there's a lot of transmission to the visual cortex. So if something's going wrong along any of these pathways, it's going to affect the eye.
Doctor, quick question.
Yes, Sonia.
Are you suggesting that cataracts could be a precursor of neural degeneration or glaucoma?
So both, but see, there's different types of cataracts, and I wrote this in chapter 6 of my Alzheimer's book, and it's not 100% delineated in the literature, but it's very clear. Cortical cataract is the beta 142 amyloid plaque that is the exact amyloid plaque detected in Alzheimer's. That's a cortical cataract. Now, the problem with cortical cataract is every eye doctor knows how to look for them. Very few do, because cortical means cortex, which means the outside. So it really doesn't affect vision, whereas a nuclear cataract is in the center, blocking the light focused in on the retina, so it disturbs your vision. Cortical cataracts almost never do. But a cortical cataract, and it's in my Alzheimer's book in chapters, I think, absolutely 6, and it's in my quarterback book too, talking about the cortical cataract and the study that Tansey, Moyer, and others did. It was a small study, but it was unequivocal. Autopsy to Alzheimer's. They showed that the extent of plaque in the brain and the extent of plaque in the cortical cataract correlated extremely accurately, that the precursor proteins in the optic cavity, the fluid, was the same as the cerebral fluid in the brain. Very, very high correlation. Now, the nuclear cataract is a early warning sign for cardiovascular disease, which you'll see shortly. So, but see, there aren't enough studies to say it's 100%, once again, focal. You can have a focal infection in the eye and you might develop a cortical cataract. You may not have that focal infection in your brain. So how you figure that out is, first of all, the treatment's the same. It doesn't matter. You don't want the cortical cataract in your eye. And it's not through eye injections or drops. You got to treat systemically. So, you look at this as everything's probability in medicine because, we're so complex. But it's all about what are my odds that is the case. Okay? So here's a book, John Dowling. The book, which is up on the screen. And I'll admit, I am a type A, probably double A. And I don't have the patience to read something this technical. I did my best. Okay. That's why I spent a lot of time going into 930 Commonwealth Ave to spend a lot of time with Dr. Tremp, just to listen to him because, he knows more. He knew Dowling, and he knew a hell of a lot more than Dowling about. But Dowling was a researcher and did good work. But, the good thing is the translation of that work is very simple. The retina is an outcropping of the brain, and neurological tissue is mainly affected by the vasculature. You can titrate back to inflammation. It's not a complicated thing. But this is what he says, the retina provides an excellent source of material for detailed anatomical, physiological, and pharmacological analysis of neural mechanism. That's what Dr. Trump did in people. They came in with macular disease, and he measured their blood and treated them systemically, and their cognitive scores sometimes improved. Not always, but talking to his widow, Zena, she told me that, the several dozen or so people that he really improved, and he wasn't advertising for dementia people at all, believe me, And the couple dozen or so that he really improved, he basically became their health coach. That's why I want to work with you folks on a weekly basis. He literally, as like the best doctor in the world, became their health coach, and that's how they got better. But some of them, not everybody gets better because the pathologies are different, and it's hard to treat people that are sick. I don't know if I told you the story, but the top functional clinic in New England, I talked to the CEO, who was an MD, and I had a connection there, and I came in and presented, and afterwards he came to me and said, you know what, this is the top, Michael, 25 functional doctors. He came to me and said, we don't really want to treat sick people. It's an unquote, but it's hard. He just wants to make wealthy people in Wellesley, Massachusetts, go from very healthy to very, very healthy. That's what he wants to do.
Right.
Can you believe that, Michael?
Absolutely.
Hey, I think I talked to that clinic that exists, and at least I didn't spend any money. I did a phone interview, and I got that impression.
I have the name. It's
I think I know, and I won't say it, but I got that
Fortunately,
impression.
I wiped it out of my memory banks. I saw his name recently, and it's like, oh my gosh. But I'm not sure how many people feel that way. It's hard. What we're doing, folks, if someone's down the continuum a little bit, remember that Gaussian curve? If you're up this curve, it's not easy, and we don't always have all the answers. We'll keep digging, but it's going to take a while, and you're going to be patient to reverse it, And so my preaching is select someone who seems to know what they're doing, and don't jump to practitioner. Follow through the process, because there's no shortcuts, unfortunately. That's the message, really. And that's what he was basically saying. It's like, we don't have the time or energy. People want solutions tomorrow. And it's easy to get someone like the Bredesen program with diet. I'm not criticizing Dale Bredesen, believe me. But if someone can respond to nutritional changes because they have a bad diet and their memory improves a little bit, or improve leaky gut in their brain, that's easy. But infection that's overwhelming the microvessels, that's a lot more complex process, and will take a while. I won't go into this, but it's really quite fascinating that the lens retains all the old stem cells, and a good eye doctor can really see sort of the history, just like you see the rings on a tree. You know, like the rings of a tree, you can tell when there are good growth years and bad growth years by how thick these rings are. In some respects, there's a forensics story in the lens. It's, you know, it's this is obviously not how big it is, but when you think of how big a cell is, the lens is a single cell. It's the largest single cell in your body, and it's largely avascular. So things going across the cell, in and out of it, it's happening at a much slower rate because of the lack of the vascularity. So that there's a history stored in that cell. We don't need to go into that. And the main reason why we don't need to go into that is because I don't know much about it.
Love your honesty.
Let's be honest. Yeah, if anybody wants, Amy, if you want to read, you know, Dr. Dowling's book and download for me, let me know.
No thanks.
Got it. But I'm not going to go into this either. But this is an extreme. Let me just see what this is. I'm not going to go into this either. But this is a really interesting experiment. This is like looking at your teeth with 3.0. Okay. This is a chicken lens taken out of the chicken and put into culture. And then what they did is created inflammation in the environment, so you can kind of see modeling here. It's kind of, this is clear, this is modeled, showing the modeling, and then they put it into a rejuvenating environment, taking the insult away, and the lens cleared up outside the body. So it just shows that if we can remove the insult, if we can be smart enough to figure out what the insult is and remove it and provide a rejuvenating environment, you can improve. That's anybody can. You know, obviously, the further down the path you are, the more complicated it is, yada, yada, yada. But that's just how profound our body is at healing. So that was a really interesting study. Just so that we understand what the eye pathologies are and how you look for them, is this is an eye. Basically, this is the eye. And the stem cells are out here, and they're supporting growth and regrowth of the lens, okay? And this white area here is a nuclear cataract, okay? It's blocking the center of where the light is coming in and then focusing on the back of the eye, so it's affecting vision. But these little guys here are called cortical cataract or cortical fibrils. And these are the 142 beta amyloid of Alzheimer's. And they, you know, so the eye doctor can see it just like you're seeing it, but they say, it's not going to affect your glasses. You know, it's only going to affect your health. But, you know, that's not the important thing. There was something else about this rejuvenation I wanted to say, but it doesn't come to mind right now. But I'm only going to go like another 5 minutes. I'm just going to cover cataract right now, and then we're going to call it a day. But, you know, this is not an unstudied area. It's highly studied, but highly unapplied. So this is the age-related eye disease study. And if anybody's ever heard of the AREDS vitamins, I'm going to show you that the study shows they're rather useless, but there was much more important data out of that AREDS study. So this was, it shows the association between mortality and ocular disorders. And it was done in the 1990s, 11 clinical centers, funded by the NIH, almost 5,000 participants. And the indications they looked at were age-related macular disease and cataract. It included early drusen or retinal pigment epithelial abnormalities. So just little globules that you can see with a fundus photo, which is a standard piece of equipment. And what they showed in a follow-up of 6.5 years is that 11.2% of the ARID participants died. And in the age group they were looking at, 45 to 70, the mortality would have been like 0.5%. So there's a huge increase in mortality. Nobody's telling you that. Cataract surgery is the #1 surgery in the world. It's a sign that the immune system's reacting to something, and they're mostly dying of cardiovascular disease. So here's the actual data. So here's baseline for this is age-related macular disease, category 1, 2, 3, and 4, and this is probability of death, and this is not relative like we talked about last time. This is absolute. These are real numbers, not fudge factor numbers. And you can see this is bleeding AMD, high mortality, whereas just the dry AMD is an increase in mortality, but not so much. Just a significant change in vision, which is really titrated back to a nuclear cataract, increases mortality. Cataract surgery, meaning the nuclear cataracts was so bad it was impairing vision that you needed to have them removed, pretty high increase in mortality. A nuclear opacity without requiring surgery, a 40% increase, whereas the cataract surgery was a 55% increase. And then if you look at zinc, we know zinc is antimicrobial, so we saw an improvement in mortality in ARID people with zinc. But supplements in general, the so-called ARID supplements, showed very little change in mortality because these are infectious processes. And yeah, some nutrients will be helpful, but oftentimes that's not adequate to overcome a chronic infection. So here I'm just honing in, a little blurry, but it's not a good original piece of data that I could grab from. But here's cataract surgery. Here's a nuclear opacity. So you can see it's like everything else. It's a continuum. You know, the more profound. And then here's a list from 2 years ago. Cataracts are an early warning sign of deadly underlying vascular or stem cell disease. It's really a sign of, deadly. So, ARIDS, age-related eye disease study in America. Perverno in Italy. Barbados, Blue Mountain. How did Beijing get there? It belongs down there, so make that 17. Beaver Dam, Rotterdam, North London, India, Italian American, Danish population, Melbourne, Reykjavik, another Indian one, cataract extraction, heart disease in women study, physicians health study, 10 study, 6-country study. All these studies come to one conclusion. They originally thought it was the surgery, but cataract surgery is one of the safest surgeries there is. It's the #1 surgery, and it's like 99% successful. And if it's not successful, it's usually an eye issue. You don't die. It's just a little surgery there. So, and there was a lot of misinterpretation, but it really is the pathology underlying the cataract that was leading to death. So what I think we're going to do is I'll introduce this, but we're going to continue with this next time. So this is the publication from 2003 and published in the Lancet by Goldstein at BU. Ashley Bush is in Australia. Tanzi is the Kennedy Chaired Professor of Neurology at Harvard. Who's higher than that? The only thing is he never treated a patient. He's a PhD. And then Robert Moore, unfortunately, last year died of a glioblastoma. I got to meet him. But he's the one that really did the study on these proteins and showed that they're antimicrobial. He published that work in 2009, 2010. But what it says is the systolic beta amyloid deposition, which is just a cortical cataract or an amyloid plaque in your brain. Supranuclear cataracts, which is also a cortical cataract, same name. In lenses from people with Alzheimer's disease. So he's showing the eye-brain connection. So we're at slide 27 out of, we're halfway there. So, do you have to do an eye test? I think it's, the MRI is much more specific to the brain, but it's also much less precise. So getting an eye test, and getting, and particularly an OCT, but I recommend all three. And if you go to an eye doctor and you want this test, please take my sheet, but also call me. What I'm going to tell you to do is you're going to tell the eye doctor, I want to be evaluated for cortical or supranuclear cataract. And to do that, they have to use the same instrument they use for nuclear cataract, but they have to increase the intensity of the light, and they have to look further into the periphery of the lens to see it. And it's kind of like, it's a really cool test. It's kind of like looking at, if I had blinds here that were mostly closed, but there's a little bit of sun coming in, you know how you'd see the dust particles that become clear? The dust particles would suddenly be illuminated by that beam of light. That's what they're doing. They're shining in very intense light and looking for any of these little opacities, like a particle of dust in the pathway of the light coming into your room through the blinds. Okay, so we'll go on to that, but you need to have them look at the fundus. That's a fundus camera. So there's a slit lamp microscope, a fundus camera, and then an OCT. And I've called a couple doctors, and they say, oh yeah, we have the state-of-the-art OCT, and then I get the OCT, and it's from the Dark Ages. That's my Boston accent. So it's kind of hard to tell, but there are OCTs now, OCTA, that really can see microaneurysms, which is, plaquing, really, and microhemorrhages of the capillaries in the retina, which you cannot see that with any other technique, really. So we can see, like in diabetes, is diabetes manifesting in disease? I don't know. I feel okay. I'm a little, I get a little hypoglycemic. Well, the OCT can see if we're seeing the earliest of pathology changes in the vessels through that technique. Okay, and there are many, many doctors that can do this, but that's why usually the Vision Source or All Docs OD, they tend to be, they claim to be more educated, and I've been invited to present at the All Docs conferences. And Kerry Gelb out of New Jersey, the head of All Docs, is probably the best eye doctor that I've come across. And then Dr. Scott Edmonds in Philadelphia, excellent. And then Mark, I can never remember his name, it's just a mental blank, but in Orlando. When you talk to these people and you tell them what you know about eye, and then give them an opportunity to have an audience with someone that gets it, it's amazing what they really do know, but probably don't disclose so many times because they're just an eye doctor. They're not even an MD. An OD is not an MD. So they're a little reticent to say, hey, this may be associated with cardiovascular disease, or this may be associated with Alzheimer's. And it's like, you're an eye doctor. What the hell do you know about that? You're not even an MD. But they're the best diagnosticians in the world for pathology. There's no question about it. So, anybody have any questions on today's content?
I wish I would have had this session with you before I just saw the ophthalmologist. I did ask for a report, and they told me, oh, no, we don't have the time. They were just a mess. So I just said, forget it. Next time I go in.
That is not a doctor you ever want to go back to anyway, if that's their attitude. I had a doctor.
It wasn't the doctor. It was his staff, though. Yeah.
Well, it's still an excuse. They're only interested in making money. They're not patient care. I had a doctor on the Cape. I sent the lady to, I don't know. I called a couple people because I used to live in Mass, and, no one really knew. So we just look at Vision Source. And I sent them a sheet, and the lady goes in, she's going to pay cash. And the doctor says, you don't need an OCT. Literally sent her back out the door. And I'm saying to myself, my gosh, we have met, Dr. Carter, we have met an extraordinary man who can see submicron.
Right.
Because if you don't need an OCT is if his ability to look at you is as powerful as the OCT.
I know, exactly. Yeah.
Hey, Dr. Lewis. What about stem cells? You know, they put stem cells in joints and stuff like that. Is there ever any time that they could utilize stem cells in the eye?
They are in Florida. There's Dr. Oh, I can't remember his name. I think it's Dr. Levy. But it's there is a group out there in Florida that they are doing bone marrow derived stem cells injected into the eye for treatment of glaucoma and so forth. And they're actually doing it in clinical trials, and they have some interesting results. You know, also utilizing stem cells systemically can potentially be beneficial. But ultimately, at the end of the day, it really kind of goes back to the milieu and just what Dr. Lewis was saying about infections. So if you do stem cell therapy, so let's say you're using your own stem cells, you know, from umbilical cord sources, but you have subacute infections, then depending on the level of those subacute infections, it can, you know, override any benefits. And same thing if you're using umbilical cord stem cell sources that, let's say that, you know, they are free from any of those subacute infectious sources, but you're then putting it into a body that has a lot of subacute infections, then it's not going to be as beneficial. But yes, they are doing stem cell therapies. There's a lot on the horizon. You know, even the traditional ophthalmological MD database of doctors is really looking at some of the alternative things to aggressively treat various eye diseases.
What we're going to do next week, even though I have another whole talk to complete here, but I think what we're going to do is have Dr. Carter, if he's available next week, just to go over his eye story and his treatments and what he recommends for eye and all that kind of stuff. And then the week after, we'll finish up on the eye thing, unless we want to reverse that, Dr. Carter. I'll let you decide. You can either go next week or the week after.
Yeah. Sure.
Yeah, but anyway, Norma, a detailed dive into Dr. Carter's experience with eye will be occurring.
That'll be interesting to hear, yes.
Yeah. So, have any questions? I put down in the chat. It's Dr. I mean, I know you guys aren't necessarily in Orlando, but you know, it was Dr. Mark Perry finally came to mind. I mean, there are plenty of others that are out there. You know, if you want to go quickly to heaven, you can go see Dr. Shailesh Kaushal. We're just kidding.
Hey, I got a question, Dr. Tom.
Sure. Alan, hi.
Hey, don't forget to say hello to Doll.
Hey, doll. How you doing, doll? Great to see you.
Hey, my question is, I'm doing the eye drops for early signs of glaucoma in my left eye. Now, since it's just kind of like preventative, should I ask for that test you just mentioned?
I mean, you should. We definitely want to see an OCT in you, Alan. We want to see a really well done OCT. I will. You call me offline and remind me. But I want to consult with you and Dahl on a weekly basis now. So you send me some. Anybody who signed up for my end of year program, send me times and dates on a weekly basis that may be available to you. And it can be in the evening as well. I'd like to just stay in touch. And, but Alan, Pastor Alan, we want to find a eye doctor in the area that meets the spec. But I think we need to look at your labs again and all that, because there's something broiling there. And you're at the point where we don't want to just treat it In the eye level, we definitely want to dive down and, you listen to Dr. Carter next week, and I'm sure you're going to be compelled to do a little more testing because you don't want to go down this path.
Right. Well, I checked on those labs. And they're usually in my folder online where I can get to them, but they're not there, and they're really strict about people coming on the VA without an appointment. But I've got an appointment Wednesday morning, so I can get a copy of them then. So I just wanted you to know I forgot about that.
Well, get everything you have as far back as you can go so we can create sort of a timeline of what's going on, trend analysis. That, because in chronic disease, it's smoldering. And so, we want to look at white blood cell counts and are they going this way, even though they're still considered normal, or are they going this way? And these are the kinds of things that we can, one point in time, I always tell people, you're a story. And if I talk to you one time, I get a little knowledge about you, but you're really a story. And we need to get that story. It's the only way we're really going to get to the root of these things and understand what your trajectory is. To give you an example, I did it earlier, I think, in the Genesis of Health. Two people can have an A1C that's exactly the same. Their trajectories can be completely opposite. But in the standard of care, they're treated completely the same because it's just one number. It's just like, I see you, Alan. Pastor Alan lives in not Elizabethton, Johnson City, Tennessee. That's all I know about.
Yo, girl.
That's not a story. Any other questions or comments?
Excellent.
I just wanted to mention that I'm glad that you're covering this topic because I don't have glaucoma, but my mother had glaucoma, and she was so diligent with her drops all her life, and she still ended up losing sight in one of her eyes, and she had many other issues. And I've always been completely frightened of that. So good to know as much as possible.
Well, the survey shows a much bigger problem, and it's a very quiet problem because people aren't talking about it because they don't have anybody to go to. But the drops are for tension, and some people have low tension. I don't care if you have low tension or high tension. There's something behind the tension or the deterioration of the nerves, and it's not like Dr. Tremp always used to say. I mean, he's a very interesting character, and yet you could take him out of context very easily. But he'd say to a patient, "You think God doesn't love you, or you think there's something else wrong?" And I always got a kick out of that, because my wife says I can get away with so many things, but Dr. Tremp, because people loved him so much, could really get away with things, when it came to talking about people's health, because they just knew he was on their side. So, but that's the deal. Any other questions? Look at that, 1 p.m. Who would have thunk it? Well, I really appreciate it. I know people want privacy. I mean, feel free to message me through the Healthy System or text me or email if you have any specific questions, because your questions are important. And, Dr. Carter knows a heck of a lot more about this than I do, so I'll compile any questions you have privately, and Dr. Carter can address those anonymously at next session, or we can deal with you directly some other way. All right, folks, happy Labor Day.
Thank you so much.
Thank you.
Have a good day.
Labor Day.
God bless everybody.
Everyone.
Yep, God bless you. Bye-bye.
Thank you.